must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
Hey, everybody. Thanks again for listening to the HET podcast. I am one of your hosts, Brandon Powen, and of course, as always, I am joined by my fellow co-host, Dr. Stephanie Wyrock. And today, we actually have a very special guest on to talk about a rather interesting field of healthcare that we really haven't covered a whole lot, and that's especially regarding vision. So with that being said, I would like to extend a great welcome to Dr. Debby Feinberg. Now, if you don't know a little bit about her, I'll briefly introduce her and then I'll let her kind of share her journey. But for those of you who are unaware, Dr. Debby Feinberg has been developing the field of neurovisual medicine, which basically is an optometry subspecialty that identifies and treats neurological and medical symptoms that originate directly or indirectly in the visual system. Dr. Feinberg has been performing pioneering work with binocular vision dysfunction, or commonly known as BVD, and is currently working at Vision Specialist of Michigan in Bloomfield Hills. So before I dive in here, Debbie, I just want to share this interesting story about how we connected initially, because I always think it's interesting when you have that kind of a connection initially. So initially, a couple of years ago, I actually lived in Waterford, Michigan, which isn't too far from Bloomfield Hills, and Dr. Feinberg's office specialist, Ashley, had reached out to me inquiring about Dr. Feinberg coming on. And I kind of said, hey, yeah, I used to work at Michigan. I used to live in Michigan, blah, blah, blah. I used to live in this unit. And then ironically, I found out that same Ashley was the Ashley that helped me at the front office of my apartment complex, which I didn't know her last name. So I thought that was such a small world to kind of have that connection. So, well, Dr. Feinberg, it's great to have you. Great to have you here with us, and thanks for coming on and for all that you do.
Oh, thank you for inviting me.
Yeah, no, absolutely. So, of course, gathering that, of course, your first job was literally 5 minutes away from where I lived. I thought that was absolutely crazy.
Yep. My father started that practice. He was one of the first enclosed malls, actually, in Oakland County. And I joined him when I first graduated in 1983.
Nice.
So, and we now are in Bloomfield Hills, just down the road from that original office.
Oh, wow. Small world.
It's amazing how, as we go through our careers, Brandon, the world does keep getting smaller and smaller. Dr. Feinberg, we had Dr. William Padula and Jeremiah Jorgensen on our show in the past, and we chatted about optometric rehabilitation, kind of like we're talking about binocular vision dysfunction. But give us a little bit of an idea on how we as physical therapists, and maybe even some other healthcare practitioners, how we need to be on the lookout for some of these visual components that may be affecting our patients.
Yeah, so, when I first, I'll give you a little bit of background on how my work started. I was, like you talk about interesting stories, I was on a double date with my husband's brother and his soon-to-be wife, and my brother-in-law is an ear, nose, and throat doctor. He was holding up a loose prism in front of one of his eyes to exercise them, he told me. And I said, well, who gave that prism to you? And he said, for the chief of ophthalmology at University of Michigan. I said, is it helping you? He said, not really. He had eye strain, eye fatigue. So I said, I'm a graduate of optometry school. I'd be happy to examine your eyes. So why don't you come on in? I'll check them out. So I found, in fact, that he needed prism, and he needed it in a vertical manner to align his eyes. I didn't know, but at the time he explained to me that he never really was much of a reader. He was a great auditory learner, but didn't read for very long because probably he had difficulty with it. And so I did help him. And he also said that he was like Mr. Magoo. He used to walk into furniture and, just was clumsy and klutzy, and things seemed to be better for him, but not really understanding how much better. 10 years passed, and he gave me a call, and he said, Debbie, I need to send you my dizzy patients. And I said, no, what would I do with dizzy patients? He says, you're going to help them the way you helped me. And he said, I was sending them to other eye doctors, but they weren't doing what you did for me, so I think you need to see them. Well, I had no idea that I could really help a dizzy person. I was quite shocked that he was asking me to take care of these people. So being conservative as I am, I said, you know what, just send me 2 people. Let me see what I can do, because I really don't know how it is that I could help them. They sent me these 2 women. They came with canes and sick bags, and they were nauseous and off balance. And I took them into my exam room, and I started to work with them. And sure enough, they were off on the vertical plane. In all my measurements, I found that they had the same vertical misalignment that he had, and that they seemed to get better, and I was happy about that. And I actually saw about 900 patients in a pretty short period of time. And I thought that was just a ton of people. I would never see more than that in quite a while. And that happened over 9 years. And then I moved to a new office, and my brother-in-law said, I need to send more people to you. And I said, well, again, I'm still learning about this work. We decided to do a free press article. Detroit Free Press did a piece on our work. And all of a sudden, the phones were ringing off the hook. In 6 weeks, there were about 168 people that called us. And they would say, how did you know our secret? We have all the symptoms listed in this article: headache, dizziness, nausea, imbalance of walking, light sensitivity. And for me, it was just almost like the conversation my brother-in-law had with me was, you have no idea, Debbie, there are a lot of people like this. And I said, I guess I don't. We didn't learn about these patients in school. So for me, it was a bit serendipitous. I wasn't really looking for this, but it found me in the way that things happen in life, where one person gets better and then they recognize that there are more people that need this care. So for our world, there's the patient that's born with binocular vision dysfunction, and then there's the patient who acquires it from a head injury. It might be a sports injury, it might be a motor vehicle accident, it might even be anoxia, so a near drowning experience, it might be from radiation, they might have even had brain surgery. And all of these patients seem to enter into a situation where their eyes are not coordinated. And they will have dizziness, nausea, anxiety, imbalance with walking, light sensitivity. And so as I started to work with this population, I realized that people started sharing the work with other people. So for example, my brother-in-law would tell another colleague. And then one day a patient came in who was in a car accident, who I helped the same way with the prism. And I got a call from the physical medicine and rehab doctor, brain injury specialist. And she said, you just helped my patient, and now you're going to help me. I'm coming for an eye exam. Sure enough, she had a head injury when she was a young girl, and she needed prism. She got better. And the next thing I know, she's sending me all of her traumatic brain injury patients. So first it was the ENT, who recognized a combination of patients who had dizziness and imbalance, whose ears were fine, and I was helping those patients. Now there's a whole new category, and these are the brain injury patients. So when you ask about physical therapy, when you work in the brain injury field, we call ourselves a team of treaters. We all work together to help the patient with all their myriad of symptoms. One of those specialists is physical therapists. So we have the good fortune of having several physical therapists who learned about our work and wanted to come visit us, observe, and then begin to send their patients for care.
Well, and I think you did a really good job kind of summarizing what that condition is. But, I want to dive back a little bit just because I'm curious, because you mentioned, kind of it being this subset of patients. What do we know about BVD in terms of how prevalent it is, and how common it is in the general population? Do we know a lot about that?
I don't think we have great statistics, but in our experience, our initial thought was that it's at least 10% of the population. But when we do conferences and lectures, we'll often pass out our questionnaire to see how many are going to score high in this cohort of unknowns. And we'll often find it's as much as 20% of the population. And the way that I like to say this is the human face is not symmetrical, but to what degree is it asymmetrical, and are people compensating for their misalignment? And I think in the world that we live in, with all the computers and the cell phones and just the screen time that we're all in front of a screen that's pretty demanding on the visual system, there's probably more people that are symptomatic with eyes that are not completely synchronized than probably ever before.
I know that you had mentioned some of the signs and symptoms of binocular vision dysfunction, but what types of what's the average patient look like? Is it an older person? Is it does this condition happen with certain other comorbidities? What does the average patient look like with this dysfunction?
I like to say they can be 4 years old and they can be as old as 94 years old. Anyone with two eyes and eyes that are not synchronized can really have the symptoms that this condition can cause. So I'll give you an example. We had an 8-month-old brought in, and it was actually, I believe, a physical therapist and an occupational therapist that knew there was something visual going on. Some of it was a bit obvious. The child had a slightly turned-in eye. The child was 8 months old. They wore a prescription, quite a thick prescription. And what was unique about it is the turned-in eye was the obvious one, but the other part of the equation is the child had clenched fists. And the parents thought this was just a neurological problem, that the child didn't unclench the fist. Well, come to find out, our colleague, Dr. Mary Jo Ferentz, who works in our office, who sees a lot of our really young children, was able to hold up a loose prism that after measuring things with this infant. And upon holding up the prism in front of one of the child's eyes, her hands became unclenched and completely relaxed, and her whole body changed. So I think we often don't know what are the symptoms that could be visually related, because they sound so different than what we're traditionally used to. We're used to having the conversation that is it blurry far and near with our two eyes. In this population, when the two eyes are not working together, they can be disoriented in space. They can tell us that they fall often. They can tell us that they're motion sick. They can tell us that they have headache and pain. They can have face ache, pain with eye movements. Many of them have neck tension. So if you look at this patient, you often want to sit across from them when you're evaluating them, even through your case history. And very often you'll see a head tilt. And the tilt of the head is actually their attempt to align images that are misaligned. And as a result of that head tilt, the head can weigh heavy as it tilts off to one side. They'll get neck ache, upper back and shoulder pain. And then there's the dizziness component we've talked about. About 95% of my patients who have this condition have motion sickness. And sometimes it can occur in early childhood. Sometimes it can get worse as they get older. They often like to tell us they prefer when they're adults to be the driver, and they don't do well when they're the passenger. And we think what's happening there is because they're not focusing on the road as much, they're susceptible to flicker frequency of movement of images and their peripheral vision. They can also be quite nauseous. We had one young girl who came from Colorado, and she had what somebody would think is failure to thrive, or maybe they thought even she had an eating disorder. She was so thin. Turns out she had this condition, and upon giving her the prism built into the glasses, she even at the end of the exam while wearing the trial frame got very hungry. And it was almost like the nausea overrode any interest in food. Once the nausea went away, which is common, her hunger, her ability to want to eat food came back.
Well, that's so interesting, just how diverse in terms of from so many different factors regarding the patient that this type of condition can manifest with. But I got to ask Debbie, because knowing that, of course, when I hear all these kind of symptoms, I'll admit my mind doesn't immediately go to vision. So what do we best know? Are there any other specific screening methods that are out there to kind of help better pick out these patients specifically, to kind of help rule out some of the others that maybe also be presenting similarly?
Yeah, so we felt the same way in the early days of doing our work. My brother-in-law actually encouraged me. I was writing a book on every patient. I just wrote and wrote and wrote. And I said, Arthur, his name is Arthur Rosner. I said, Arthur, I can't write a book on everybody. We've got to have a more systematic manner to capture this information. He said, well, you need a screening tool. So together, between what he heard from his patients, what I was hearing, we developed what we call a binocular vision dysfunction questionnaire. It has 25 questions, and it sort of covers the domain of pain, the domain of anxiety, the domain of dizziness. And so, for example, I'll read off a couple of questions to, do you have headaches and facial pain? Do you have pain in your eyes with eye movement? Do you have neck and shoulder discomfort? Do you have dizziness? Do you get dizzy when you perform near activities or far activities? Do you get lightheaded when you bend down and stand back up? Are you unsteady when you're walking? Are you overwhelmed or anxious while walking in a large department store? What's interesting is when the eyes aren't working together as a team and we're picking up in a very overstimulating environment like a department store, so many objects in our peripheral vision, the patient typically becomes very anxious because they feel actually unsafe. They almost feel like they're going to fall down. They don't feel grounded. So anxiety is just a really unique characteristic of this population. My very first patient, one of my very first ones that I helped with PRISM, when she had the trial frame on, she said, did you give me Valium? I said, no. Is that how you feel? She said, I feel so calm. I'm not used to feeling this calm in my body. So I was a psych minor in college, and I was really fascinated by the connection between anxiety and disorientation in space. And it's known in the literature. If you Google dizziness, it often says that these patients can be anxious. But you also could Google anxiety, and there's a thought that they're making themselves dizzy. Well, I disagree, because in my world, I actually can take away dizziness and I can take away anxiety, and it happens pretty expediently. They're often riding in the car makes them dizzy. That's number 11. Do you get anxiety because of your dizziness? Do you find yourself tilting your head to one side? Do you have poor depth perception? My brother-in-law, again, was clumsy, klutzy, so that's very common that they can't judge distances accurately. Do you have shadowed vision at far, shadowed vision at near? Very few of these patients actually describe diplopia or double vision, but nothing's quite right. Everything has like an extra, like almost like an eclipse image around it. Do you have glare or sensitivity to bright lights? Do you close or cover an eye with near and far tasks? Sometimes it almost becomes a strategy to get rid of some of their symptoms by closing an eye. Later on in the talk, I'd like to share with you a cover test that we created to help people get sorted out. Do you skip lines with reading? So imagine one eye's on one line, one eye's on the other. I have no idea what I read. So very often comprehension is a problem, and they'll use rulers to find their place, when in fact if we put the PRISM into their prescription, they can read without skipping lines. Do you fatigue with close-up tasks? Do you have blur at far, blur at near, which are pretty obvious standard vision questions? Do you blink to clear up images near and far? Do words run together when you're reading? Oftentimes they say, the children will say, the words are swimming on the page. And then do you have difficulty with reading comprehension? So those are the 25 questions. It's on a Likert scale, never, occasionally, frequently, and always. And we'd like to make this questionnaire available to your audience. For the adults, it's 14 and older. We've also developed 2 children questionnaires, one for the 4 to 8-year-olds and one for the 9 to 13-year-olds.
Well, I think that's fascinating. And, Debbie, I have to ask, because knowing that you guys developed this screening thing and, you've gotten it kind of formulated to what it is, what do you guys know about like how reliable and valid this screening measure is and actually being able to diagnostically pick out these patients?
It's become the most powerful tool that we have. We did have it validated by a statistician at University of Michigan and at St. Joe's and Ann Arbor, 2 different hospitals. But our ultimate goal is to publish and get this questionnaire, as a validated tool formally in the literature. But for now, this is being used by physical medicine rehab doctors, by neurologists, by ENTs, and it is truly a valuable tool. So for example, if a patient scoring 15 or higher on this Likert scale, 0, 1, 2, 3, is potentially a candidate for care. The higher the score, the greater the symptom burden, and the more symptomatic, obviously, they are. So it's become quite important. Physical therapists use it in their practice, and anybody who really knows about our work I say to them, before they think of sending anybody, absolutely have them fill out this questionnaire, and then we're all going to know if they're a candidate for care. And we do have a URL that might be helpful to share. It's called isitmyeyes.com. So anybody going on the internet filling out punching in isitmyeyes.com, up will pop a questionnaire, and they'll be able to fill it out online and then press send, and it goes right to our office where we'll be able to score it, and we call everybody back. And we do have colleagues now around the country that we've trained. There are 21 colleagues that I've trained to do this work, and we're able now to, if I get somebody who's calling from Texas, we now have 3 Texas doctors. So the most important thing is people were traveling from all over the country to our office and all over the world, and I felt like that wasn't acceptable. We needed to set up a training institute. So the institute itself is about 4 years old, and we actually next month will have 2 doctors coming from Arizona, 2 optometrists. So if you have people listening to your podcast from all around the country, on our website under doctors, you can actually see the map of the U.S. and the names and contact information of our trained neurovisual specialists that they can contact.
I think that, this work that you've done so far it seems to have really helped a lot of people. And it sounds like the prisms are kind of the main intervention that you utilize to help these people. Can you tell us a little bit about prisms? And then if there's any other treatments that you apply or recommend for people with BVD?
Yes, let's talk about prism. So all of us may remember in school when we looked at a prism, we saw how they would bend light coming in through the base to the apex and bending back. So prism is, in our world, prism is a lens that's used to move an image and ultimately to synchronize the images that each eye sees. So what we often do with all of our tests, we have about 14 different tests that we do that are all what we call binocular vision tests to see how are the eyes working together in free space. And we can actually see that maybe the right eye sees high on an instrument and the left eye sees low. When we use prism, we can actually bend that light and apply the prism to bring the images into alignment with each other. Those prisms have an increment number, let's say 2 diopters, and then when we use that prism, we put it into a trial frame to then bring that image into one single image. As I mentioned, very few people see double, so they may describe shadowing, and we'll actually be able to get rid of the shadowing, the light sensitivity, by using these prismatic measurements. Then we apply them, put them into the trial frame, and the most important work we do is movement in space. We don't stay static because that's only one way to see the world. We have to be able to move and navigate in it. We have a 30-foot hallway, 4 foot wide, that we use for our patients to navigate down. And we'll actually observe them drifting to the right or drifting to the left. And as we apply the prism, we have them walk that hallway again, and oftentimes their gait will straighten out and they no longer will drift. So we'll use those kind of before and after strategies to be sure we're really taking care of all of their symptoms.
Well, that's really interesting. I know you had kind of mentioned, of course, how they're fitted and such like that. I'm curious, just how is it like from a patient standpoint? How is it like, how does someone get it? Like, do they have to go through a specific, how do they get it from in terms of like obtaining the prism? Like do they have to do anything more through insurance or anything like that? Or is it pretty much like, what does that entail specifically?
So we call our evaluation a neurovisual medicine evaluation. A standard eye exam, if you go to most offices, they might spend 20 minutes, maybe 30 minutes. When we talk to our patients on the phone, we let them know in advance they're likely to be in the office for as many as 2 to 3 hours. Now, they're not with me personally for the entire 2 to 3 hours, but between the screening and they have 80 minutes with me in the exam room, which can be that detailed history, all those tests, all those provocative tests. And those will all be covered either by a medical insurance, that they have, or in some cases, it would just be a cash pay basis. So it just depends on what insurance they have. And my staff is well versed to help them find out what the cost would be for them to come for care. The glasses are just glasses. That's the important thing that, we all know what glasses cost around the country, and you can have a least expensive frame or a more expensive frame, but the ultimate goal is not only get the perfect prescription, but then using the prismatic lenses built into those glasses. We're very detailed in how we manufacture them. We have a lab in our office to make sure that we're doing just spot on work, and the units we're using are so small. We're very particular about all the work that goes into making them just right.
That makes sense. And, I got to ask, because of course we're talking about treatment for this management of this condition with prisms. I've got to ask, what do we know about what evidence says regarding the effectiveness of prisms in kind of short and long term? Like, from a research standpoint, do we know that, like, does prognosis depend on signs and symptoms or any other things that can kind of influence that outcome?
So we have done our work now for 25 years. So we have seen over 10,000 patients. And the continuity of care is very significant because the patients often know they need to come back to us because there's not many people doing this work. So the nice thing is we do have the data that shows what happens over time. And pretty much the patients are stable in their prismatic correction in that first visit. They often are seen, by the way, twice. They're seen initially and then for progress assessment 1 month later. But they will be seen annually. And in looking the data over all these 25 years, we don't have patients that need big changes in the prism. They're often stable after the first couple. Sometimes just simple aging changes where maybe the bifocal is going to be changed. Occasionally we'll find small units of prism that are needed to be adjusted as the patients get older. But for the most part, they're stable. The efficacy of our work, we did a study. We've done 2 retrospective studies, one in the Journal of International Brain Injury and the other in Physical Medicine and Rehab. These are both peer-reviewed journals. And in both cases, we looked back at the data, and there was close to an 80% improvement in symptoms on those 2 visits. So we're very comfortable with knowing that if someone's a candidate, the most important thing is they fill out the questionnaire. If they're a candidate, coming for care is the next step. Because during that first visit, whatever symptoms they have, patients will experience a 1/3 to 1/2 reduction in symptoms on their very first exam. And if they take the glasses off, everything returns. All their symptoms return. So it's pretty straightforward. We often like to call it a visual orthotic. So imagine if I have 2 legs, that one leg's shorter than the other, you might give me an orthotic in my shoe to even out the leg length. We think of the same thing with the prism and the way the alignment works, is if the eyes are ever so slightly off alignment, if I'm able to align the images, everything seems to settle out and the symptoms reduce. So we call it often a visual orthotic.
I think that that's a really effective way to metaphoricalize that, because I think it's interesting that just putting on those glasses can fix all those problems. You mentioned that you've done 2 retrospective studies on this. Just in general, with the use of prisms or in the area of BVD, what are some of the limitations of this research?
The most important thing that really lies ahead of us is that we need a double-blind crossover study. And that's something that we have as our ultimate goal. And we did get some funding for a study many years ago, and I was unfortunately a terrible recruiter, because knowing how I could help people, I was not very good at recruiting them, because I knew we had, for example, a sham pair that had no prism and a sham pair and a pair with prism. And we were supposed to give the patient each of these different pairs. And I was only as effective as recruiting 9 people, because once I knew how much better they could be, I had a hard time recruiting them to know they weren't going to wear the right pair for the first 2 weeks. So that was my fault in the early days. And at this point, I think the most important thing is we do a double-blind crossover study to prove the effectivity and prove it to others who don't know about this work. And then I would say the validation of our questionnaire. Those are 2 big goals that lie ahead of us.
Gotcha. Because it's always good to kind of gather. I mean, every time we're talking about research, of course, we want to look at kind of the strengths and limitations of it, and it always comes down to more research is always needed. But I want to kind of dive a little bit more into maybe some other confounding variables or some things that might potentially kind of affect prognosis, apart from kind of what you've mentioned. Are there any other factors that can significantly affect the prognosis in these patients? Like one big thing that comes to mind off my head is diabetes or having prior visual issues. Like, do you find that a lot of those and maybe other factors can contribute to someone's outcome as well?
So conditions like diabetes or hypertensive retinopathy, where the actual retina has been, in some cases, in extreme cases, been harmed, and now all of a sudden their actual foveal viewing isn't in the predictable place, they may require what we call eccentric fixating. And when that happens, we're working with PRISM a bit differently. We still can help these patients, but it's a bit more complicated to align those images because of the change that's happened at the retinal level. But in general, if somebody's got controlled diabetes, it wouldn't be a reason why they wouldn't be successful with PRISM. Some of the confounding variables that you're asking about, one I can definitely explain, has to do with medication. If patients are on certain medications like muscle relaxers, anxiolytics, anti-anxiety meds, SSRIs, sometimes what we find with medications is it over-relaxes the eye muscles, making the predictability of the PRISM unit that they're going to respond to more challenging to arrive at. But the way that we've sort of circumvented this is if a patient's on medications that they cannot eliminate, let's say it's a seizure med, we just know in our mind we may not get them to full recovery. We can certainly impact their symptoms. If they're on medications that they're using because the symptoms that we're ultimately going to treat, sometimes just giving them that very first prescription that quiets their nervous system, calms their anxiety, motivates them to go to their doctor and ask if they can be helped with a weaning schedule to wean off of those medications. And ultimately we can find, with a clean system, we can help them get to more of a final effective prescription. And one more thing I want to share with you is this about 3 years ago, you asked about confounding variables. I discovered there were a number of my patients who were getting better, but not all the way better as I had hoped. And what ended up happening was a woman came in with a set of Bose headphones, and she wanted to have the entire exam with the headphones on. She was a patient who was a survivor of a pretty severe motor vehicle accident, and she was doing well with her PRISM, but she asked if she could wear the headphones during the exam. She said, by the way, you need to write down the name and the brand of this headphone. It's the most effective. So I did, and I thought, I can't imagine my patients wearing headphones all the time, but I found it quite fascinating. I later learned that this Bose product was now going to be available in a smaller unit, a device called the QC20, which was just ear wires and with a little battery. And when I saw that that was available, I thought, maybe my patients would consider that device, but still not quite knowing how they were going to utilize it. So I bought a set. It was quite expensive. They ran, I think, about $300. And I let it sit in the corner of my exam room, not knowing who I would use it on. A young man comes into my office wearing a hat and sunglasses to protect him from light. And he said, you have a really noisy waiting room. I thought to myself, not really. It's actually quite quiet out there. But I thought maybe he'll be the one. So I pulled out the earbuds, noise canceling earbuds. And I said, Danny, would you mind if we use these earbuds for just a trial and see what happens? And he put them on, and he took off his hat, and he took off his sunglasses, and he said, wow, I feel so much better. I said, what's happened? He said, I don't know. I just feel like I don't want to take these off. Now, to tell you about sound sensitivity, I have to go back a little ways. About 10 years prior to this whole sound exploration, I was finding that a number of my patients had vestibular symptoms, dizzy symptoms that weren't being fully resolved by the glasses. And so I was exploring sending them out to specialists who looked at, let's say, inner ear issues that might be causing it. Many of them said they had sensitivity to sound as part of the condition. So we were exploring, let's say if we can help them get figured out in this manner. There was a condition called superior semicircular canal dehiscence, which is a teeny tiny hole in the deep inner ear structure that can actually happen from head injury. So my thought is maybe they have this condition and just need that little hole closed up. But most of these patients were told they were just fine. So, and part of me didn't believe it, but I was accepting of it because what else did I have to do for them? But when this series of patients who came through. And by the way, we're now 3 years down the road. There's 600 of them. I discovered that about 50% of my traumatic brain injury patients have hypersensitivity to sound. So in employing these devices, I actually discovered that many of the symptoms I'm treating with the Prism, they're actually responding to with the headphones. For example, they are less anxious, their gait seems to stabilize, some of their nausea goes away. So we're doing some research into this new area. And I want to share with you that in the 1930s, you may know that they had EENTs, ears, eyes, nose, and throat doctors. And in the 1930s, the eye people went one way, and the ear, nose, and throat people went the other way. So we share some remnants of each other's tools. For example, optokinetic drum is sometimes used by an optometrist and by an ENT. And so here's my brother-in-law, right, the ENT, and here I am, the eye person. In many ways, I feel like we're bringing back these two fields that need to be reconnected and re-explored for really helping all of our patients. I have since sent off some of these patients who needed these earbuds for full-time wear, and they in fact have been found to have dehiscence of the canal bone. And several of them have had operations to close the hole, and they no longer need the earbuds. So in some ways, I look at these sound canceling devices as almost a diagnostic tool, one in which I can employ if I've identified that the patient has hypersensitivity to sound. We actually use a validated sound sensitivity tool to sort them out to make sure we're using them on the right person.
I think it's pretty fascinating that, we can use some of these devices to help our patients. It's a conservative way to treat them. It doesn't really involve any surgery. I mean, it sounds like over the last few years, you've really done a lot of work in trying to kind of delineate a lot of this. What do we still not know when it comes to BVD from a research standpoint? And how has your team gone about looking for answers for these questions?
I think that what we don't always know is, who's going to be the candidate, so that's why this tool is so important. In terms of the effectivity of the treatment, who are our complicated patients that they're still trying to figure out? Sometimes it may be proprioceptive. We work with patients who have neuropathy. So what my brother-in-law always taught me is it's the eyes, the ears, and the proprioceptive part of balance that will play into our being stable. One example of a population that we're recently starting to explore is maldebarkment syndrome. These are patients who go on a cruise, go on a boat, they get off the boat, and they still feel like they're on the boat. So we've worked with a number of these patients who they eventually equilibrate, but it takes them a long time. So we're looking into seeing how many of those patients need Prism so that and we have found a number do very well. When they get off the boat, they re-equilibrate faster because now 2 out of 3 systems are stabilized. They're now on firm ground, and now their eyes, which were misaligned that we didn't know, now they're stabilized. So even if they have, let's say, an inner ear dysfunction, that can be overridden by using at least stabilizing 2 of the senses.
Interesting. And Debbie, I kind of want to just kind of follow up a little bit because I recognize now that clinicians and even different healthcare provider roles, so not just physical therapists, but maybe anyone else in a different setting, say they've screened a patient, provided this questionnaire, and there's definitely a sense that there could be a relevant visual component. Where would you recommend that clinician refer that patient to best help out that individual? Because I recognize that not everyone can send it to that one clinic in Michigan.
Right. So the mandate for me was, it happened after a young man got on some Greyhound buses from Austin, Texas, and literally in 2 days traveled to my office for care. When he hit our door, I said to my husband, who's one of my primary research partners, I said, I have to teach what I know. We have to move our work forward. So it was on that day when he came and I went home and I said, you have to take everything that I understand in my mind and I have to have you translate it into manuals. So we created an 800-page manual that since slimmed it down, but we then set up our Vision Specialist Institute. So our goal is to train as many doctors around the country as we can so that everybody can get this kind of care in their hometown. So what they can do now, we have 21 doctors, is they can go to Vision Specialists of Michigan, go to our website, as I mentioned before, click on doctors, and then they can scroll down to see doctors who are neurovisual specialists. And amongst my 21, one is in Australia, so quite a bit further away than the U.S., but if they go to a doctor who understands this condition, they will get the care that they need. And the goal, again, is to hopefully train more doctors. I do want to share one real quick thing that I found helpful. It started with a patient. We talked to people from all around the country and even the world. And there was a young man who had a ski accident out in Norway. And yes, he scored high in the questionnaire. But of course, I was very nervous about having to travel all the way to the United States and to Michigan for care. So I decided that I had to find a simple way to prove that, in fact, he had binocular vision dysfunction. So we started something we call the 5-minute cover test. We've since renamed it called Experience the Difference. And basically, and I can teach you over the phone what this is all about. You have a patient sit in a comfortable chair. They look off at a blank wall 8 feet away. You ask them to allow their head to go side to side, ear to shoulder, back and forth, and ask them, which is the side that you feel more comfortable going towards? So right now, for example, I'm going to my right shoulder. I can go much further to my right than I can to my left. So what we say when someone can go more to the right, that means my left eye is highest to the ceiling or closest to the ceiling. We call that the high eye. We then ask the patient to sit in that comfortable chair, identify what symptoms do they have before they get started. What's your dizziness? What's your nausea? What's your headache, your neck ache, your sensitivity to light, and your anxiety? 6 categories. And then they might say, I'm a dizziness of 5 or I'm a headache of 5. So then you have them sit in that chair, set a kitchen timer or their phone for 5 minutes. In this case, it would be my left eye is my high eye. I would cover my left eye with my hand for 5 minutes. If you're wearing glasses, you cover it over the glasses, contact, same thing. You block all the light to that one eye. At the end of the 5 minutes, before uncovering your eye, you ask yourself, what's my headache now? What's my dizziness now? While still covering that eye. In our experience, people have a 1/3 to 50% reduction in symptoms in 5 minutes. The other interesting thing is when they uncover the eye, very often all the symptoms will return. And here's the best way to explain that 5-minute cover test. This is a 2-eyed problem. So by simply getting rid of one of the images and blocking light to it, we've pretty much taken away the fighting eyes. And it's the very fight that these eyes are going through all the time, creating the headaches, creating the moving images, the dizziness, that by taking away that second image, it quiets down their symptoms and it proves to them that they actually have a 2-eyed problem. I'm going to provide that handout to you as well as the questionnaire so all of your colleagues can learn how to do the 5-minute cover test. It's explained on this handout.
So if you guys want to check the show notes, we will have that handout available to you. You had mentioned earlier that BVD was not something you learned in school. Is it covered now in optometry school, or kind of where is this condition at as far as educating new graduates or even experienced clinicians?
I don't think it's being taught the way that it unfolded for me in terms of looking at the inner ear, looking at all these different symptoms. But I will say there is some progress in the category of concussion and looking at head injury and looking at some of these symptoms. In my experience, what I'm learning is more often than not, the treatment protocol tends to be rehabilitation, tends to be vision therapy, tends to be exercises of the eyes. I think little by little, we're seeing some of my colleagues also using Prism to help these patients. I just don't think the numbers of the exposure and the detail is quite there yet. But I'm hopeful that as we get more into the more complicated cases of these head injury patients, that more sharing will occur and more training will occur in this specific category.
Well, and apart from what you had already mentioned there, given your experience with doing this work and with teaching and trying to get the message out there about this specific avenue, I'm curious what have you learned about this topic, or what have you learned in general from doing so much teaching other providers regarding this issue?
The biggest thing that I've learned is that there's a huge disconnect between the symptoms that we're treating, let's say in the medical space. So the neurologist that sees the headache patient, the ENT that sees the dizziness patient, the dizzy patient, the psychiatrist that sees the anxious patient. I think the disconnect for us, and we're going to keep fighting to get this information out there, is that no one is thinking about the eyes. When I did my TED Talk, the theme of my TED Talk that I did in Detroit about 4 years ago was, could it be the eyes? Could it be the eyes? And I think therein lies the area which needs tremendous exposure. And the more we can educate people about a simple questionnaire, about a simple cover test, I think my colleagues are going to start to know that the patients they're the most frustrated with, that they're not getting answers from, and getting better, and the medications aren't working, that they might think about this condition as another tool in their toolbox to help these patients. They are really, I call them silent sufferers. They look fine, but they don't feel fine. And they almost are frustrated to even continue telling their story. They don't feel listened to. But in reality, I really think there's just lack of education that we have ahead of us.
I think you make a really good point there about, the disconnect between healthcare providers. And I know that that's something that we strive to improve, communicating with our colleagues in medicine, in optometry, in physical therapy, in occupational therapy. I know you've provided us with a couple of resources to learn more about BVD, but do you have any other recommendations as to resources that our viewers can go to in order to learn more about this condition?
We've been accused of having a Wikipedia kind of site. So I think if they can get to our website, Vision Specialists of Michigan, it's just packed with information. It's packed with videos. It's packed with blogs. It's got our 2 studies there. I would say, because we were sort of one of the original offices that began doing this work, and because we're so driven to get the science out, I think starting with our office website, Vision Specialists of Michigan, is probably the best place to really get that information. And then from there, our office is always available to answer questions and help people learn more about it. I even have one of my favorite videos we did 3 years ago. It's called Colleague to Colleague. And originally I thought I was going to do a documentary on my work, and then it turned out that the people that came to share their exposure to our work just said, let's just talk about what you're doing. And what you'll find interesting is there's a neurologist, there's a neuro-ophthalmologist, there's a physical medicine and rehab doctor. So in this video, these multidisciplined physicians are talking about how they were sending their patients who they couldn't figure out to our office. And we're so happy to have this as an available avenue for care. So I think I'd still go back to the website, would probably be the best place.
Sure. And Debbie, I really want to again say thank you for all the work that you've done regarding this avenue. And of course, as always, for coming on the show to speak with us this evening. But we always like to end each episode with kind of this final question, because with our podcast being called the Healthcare Education Transformation Podcast, we of course have to ask you this. If you could change one aspect of healthcare education, whether that be optometry or other healthcare provider related, which aspect would you change, and how would you change it?
What I would change is I would tell all of my medical allied health professional colleagues that we need to be a team of treaters. We need to communicate with each other. We need to step out of our silos, and we need to really go visit each other. We need to see each other in our work settings to understand how to integrate the information that we all know. I love the Mayo Clinic example. I love these places where all these different specialties are under one roof. Being that we don't have those everywhere, the most important thing that we can do is make it a point to learn what others are doing and try to make sure that our referral drawer has all of those specialties in it, that we know that we don't say to the patient, can't help you, stop them at the door, but instead we have the next place to take them to to get them the rest of the way better.
I love that. And I think many of our listeners would agree with you on that we need to get out of our silos and we need to make sure we're collaborating to do what's best for our patients. I'm thinking that a lot of people are going to be needing to know more information about how to reach you, because I'm sure that they have a ton of questions as this talk has been extremely interesting. Where can people go to learn more about you or to reach out if they have a question on social media or email?
Sure. I'll give you my email address. It's Dr. Debby, DRDEBBY, at VSOFM.com. And I can even give the office phone number if that would be helpful, 248-258-9000.
Well, perfect, Debbie. And thank you again, so much for coming on the show to speak with us this evening, because I think this has been a very enlightening topic, because I will concur with your statement that I don't think it's something that a lot of people are as super familiar with in healthcare. So I think it's good that we were able to have a really good discussion on some of these key avenues from a clinician point of view to really help best recognize and help get these folks to the right people. So I really appreciate your time, your work, and thank you for coming on. It's been a true pleasure.
Thank you for having me. And I want to applaud you for all that you're doing to reaching out to your colleagues to expose them to new ideas that they can adopt in their own practice. So thank you again for including me.
Well, of course, that is just one of the many things we try to do on the podcast. And we appreciate people that are specialists in different avenues that are willing to come forward and share it. So the thanks is all to you.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available in our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost. Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.